organizing one orientation program on journal club. So we also have discussion on 2 journals already distributed to our delegates. So to initiate today's academic program, we have 2 esteemed faculties as chairperson, Professor Subir Kumar Maulik sir, who is the ex-professor of pharmacology at AIIMS, New Delhi, and who is an excellent researcher in the field of pharmacology. We are really fortunate to have sir with us today as chairperson. And also we have Professor Jyotirmoy, who is an professor of internal medicine at Araujo Medical College. Sir also is the Dean Elect of Indian College of Physicians, and sir is an esteemed member of API. So we are really fortunate to have Professor Jyotirmoy sir with us today as chairperson. And to introduce to the subject, we are really fortunate to have Professor Shantanu Kumar Tripathi sir, who is an noted clinical pharmacologist in the country, and currently he is now the academic dean at Netaji Subhash Medical College, Patna, and also he is the clinical director of research wing at IIILTS, West Bengal. So welcome, sir. So please proceed. May I request our chairperson, respected chairperson, Professor S.K. Maulik sir and Professor Jyotirmoy sir to have some introductory comment. Then we have to proceed towards the scientific event that will be carried out by Professor Shantanu Kumar Tripathi sir. Over to our respected chairpersons. Maulik sir, you have to unmute yourself, sir.
I have more gray hair, so I'm advantage of my gray hair. Hello, Dr. Jyotirmoy.
Yes,
Nice to see you on board.
thank you.
And I think it will be a very interesting. I'm very, very grateful to Indian Pharmacology Society, West Bengal branch, and Dr. Shantanu Tripathi and this Academy to have such an interesting academic exercise. I can call it e-journal club, which is very much needed for young pharmacologists as well as mid-career pharmacologists. So, uh, thank you, Dr. Shantanu, for taking this initiative and for inviting me to attend this journal club. Over to you. Over to you.
Hello, sir. First, I am thankful to Professor Shantanu Tripathi, Professor S.K. Maulik, and Dr. Shambo Samajdar and the Indian Pharmacological Society for inviting me in such a program. For two issues I want to highlight, for which I am very much inspired and very much impressed. One is journal. There is a multiple journal all over the world, and we read it. But how will translate in the clinical practice? That is our challenge. Whether whatever is published will accept and will translate in clinical practice with clinician, we have a challenge. So how to interpret the journal, one article, that is a major issue. This to the practicing physicians. Number one. Number two, I am very thankful as I am not pharmacologist, that they have invited me. And in my Association of Physicians of India, we are working very closely with the clinical pharmacologist with guidance of Professor Shantanu Tripathi. For last 20 years, I am with him, and with active participation of Dr. Shambo Samajdar. So both society, if can act together, can work together, can have a good outcome in the. We can give some direction to the clinical practitioners all over the country. So I appreciate such initiative and hope every participant will enjoy the today's proceeding. Thank you, Dr. Shambo.
Thank you, sir. So now may I request Professor Shantanu Kumar Tripathi, sir, to please come up. Sir, are you there, sir? Sir, you have to unmute yourself, sir. Yes, sir. Now you can, sir.
Yeah, it was actually stopped from your end. Okay. So I'm audible now?
Yes, sir.
Okay. First of all, I must thank the organizers, particularly Dr. Shambo Samajdar, and then, of course, respected chairpersons, Professor Maulik and Professor Pal. So for the kind introduction, and I am here today to spend a few minutes discussing about Journal Club, its value as a learning tool. So it's a very common practice in all, particularly postgraduate curriculum, medical curricula. We use Journal Club as an important exercise, but I'm afraid that many times we do not really appreciate the real value of Journal Club and the way and the manner in which it should be ideally practiced. So that made us to consider to have e-journal clubs, and it was also thought relevant to, before the actual discussion on two journal articles, let us have a general kind of discussion, brief discussion on what is a journal club and how a journal club session should be organized, etc. This is a very brief presentation, rather an introduction to the more serious sessions on two articles to be presented by two scholars or experts, and based after that there will be further discussion. Can I have the next slide, please, Dr. Shambo? Yes. So this is the introductory slide. We all know about Sir James Paget. Okay.
But Shantanu, you are not audible.
Third reason for which he should be known is he was the person who actually introduced the concept of journal club, and this is quoted by Linzer in 1987, whereby he mentioned that for the first time this word journal club was mentioned in London between the years 1835 to 54, and in the memoirs of Sir James Paget describing the situation in St. Bartholomew's Hospital as, quote, some of the pupils making themselves into a sort of a club had a small room over the baker's shop near the hospital gate, where we could sit and read the journals, and where some in the evening played cards. So basically, this is how it all started. A few enthusiastic young medicos, they wanted to, when they assembled and started discussing on medical issues, and some of them have read some interesting article in some journal and wanted to share such knowledge and such information with the peers. So they thought, why not discuss when we assemble here for a cup of tea or a cup of coffee? So that's how it all happened. And so the concept of calling it as a club, okay, with a journal or with a journal article. So that's how the name came. And it was, the history dates back to a little less than 200 years, almost more than 150 years, 1850 around this happened. Okay. And then can I have the next slide, please? This is how we can think of a journal club. Basically, it's a group of people who meet to read and discuss journal literature. The purpose is to share knowledge, exchange ideas, to stay current in a field, to stay updated, to gain deeper understanding of a given topic, to afford continuous learning, to develop critical analysis skills and translate research into practice, translational science. Next, please. Of late, relatively much later, it is 20 years back, in medical teacher, this came as a definition what a journal club is, and they highlighted the activity part of the journal club, and that is the educational interventions that can improve reading habits, knowledge of clinical epidemiology and biostatistics, and the use of medical literature in clinical practice for postgraduate physicians in training. So it was in 2001. This is how it was defined in this journal, Medical Teacher. On the other hand, this is another definition which highlights the journal club as a group of individuals. So the previous earlier definition is highlighting on the interventions, activities in the club, while this in this definition, it gives more emphasis on the group of individuals because it's called a club who meet regularly to critically discuss applicability of current articles found in medical journals. This is important to highlight because it is a group activity. Okay, not just it is the responsibility of one person who is going to make a presentation without bothering or without involving other people who are listening. The listeners should not be passive listeners. So it is an activity, it is an active involvement of all the people in the club. And some of the people are given assigned some special responsibility. They are called members of the core group. We'll come to that. So journal club can be considered as an open forum for professional or disciplinary group to meet and critically evaluate the scientific literature duly published in a journal. And it provides an opportunity for professionals in a variety of roles to collaborate and discuss how the relevant research literature can be translated into clinical practice, education, administration, and further research. So this is how they have summarized. Going back to the little bit of history, it all started with mid 1800s, 19th century. Okay, and at St. Bartholomew's Hospital, London, as we have just mentioned about Paget, involvement of Paget. And then in the next 25 years, it became very popular in McGill University, Montreal. And then in the next 15 years or so, in Johns Hopkins, it was taken up at Baltimore. Can I have the next one, please? The goals of the journal club activity is to keep abreast with the literature, promoting evidence-based practice, learning research methods. This is also important. Many times we read or select an article just in order to highlight the research methods that has been applied there, in order to familiarize ourselves with such research methods, whether in this kind of objectives, this research methods, how it is more relevant, and whether in similar kind of objectives, we can use the same kind of research methods into our own activity, future research activity, etc. Clinical decision making, epidemiology, statistics, these are also other key areas which would attract the attention of a presenter of a journal club, and that is how a particular journal article is chosen for presentation in a journal club. Gaining critical appraisal skills is also another goal which is highlighted into our postgraduate curricular training. Critical appraisal skills. Informing guidelines development also is an important because while we are developing guidelines, treatment guidelines, it is important that we have to do a lot of literature survey, and from there identify the right kind of article and discuss among ourselves so that we can get necessary inputs to be utilized in the guidelines development. And finally, fostering continuing professional development and lifelong learning skills also developed through journal club exercises. So the journal club core group, okay, actually act as the journal club champion. The responsibility of the different members of the core group and the key roles within the journal club include, these are the key members: 1, journal club facilitator; 2, continuing education coordinator; 3, publicist; 4, timekeeper; and the 5, evaluator. So these are the 5 key members of a journal club. I thought we should rather practice like this in any department. There could be a small core group, and this core group will be functioning as a core group for the journal club. And in postgraduate departments which have good number of postgraduate students, they can be given this responsibility in a rounded fashion. Okay, for some months, one person can act as a facilitator. Next few months, his role changes to a coordinator, continuing education coordinator, etc. How the responsibilities can be shifting. The facilitator prepares in advance of the meeting and leads the discussion that is participated by everyone. The facilitator to follow essential 12 steps like these: identifying an article, working with the continuing education coordinator and evaluator, that is the role of the facilitator. Then reading the article prior to the journal club meeting, okay, among the core group possibly, completes the appropriate review form. So in the journal club, that review form is to be pre-circulated among all the listeners or all the audience members. Preparing questions to stimulate group discussion, that is also important, and that is a responsibility of the core group people. That facilitator follows the guidelines for the group participation, starting the journal club according to the scheduled time frame, introducing the rationale for selection of the article, why at all this article was selected, what is great in that article. Okay, then poses an initial question to initiate the discussion. Next, please. Providing feedback to the group participants, responding to questions and comments, encouraging and respecting differing viewpoints, encouraging discussion by all participants, ensuring that total journal club time frames are observed, allowing adequate time for a discussion, application to discussion of application to practice, that is translation, education, administration, and research application in these areas are also to be discussed. Finally, summarizing the discussion and implications for healthcare practice, education, and research, allowing time for evaluation of the journal club process and outcomes. The pre-designed questionnaire has been already circulated. Then concluding the journal club meeting according to the scheduled time frame. And coming to the next, this is the role of the coordinator, the continuing education coordinator, preparing the materials needed to complete the application for the continuing education credits for the journal club, if it is so desired by the target group. The publicist has also some precise role to develop a communication plan and a calendar for the journal club. He or she would communicate not only to the topic, the date and time for each journal club, but also the outcome of the report of the same, follow-up. So that is the role of the publicist, communication mainly. The evaluator would solicit feedback from the participants regarding the process and impact of the journal club on clinical practice, education, and research outcomes. And the evaluator would collaborate with the coordinator, the continuing education coordinator, for reviewing the evaluation forms from programs. Next, please. And then we have discussed that given the nature of the article, okay, whether it is a clinical article, that means review article, clinical review article, then how it is to be reviewed. There are some questions. I'm not going into details of it, but this can be used as a kind of checklist for all those who are going to prepare for a given journal club. Or this all depends on the nature of the article, in fact, whether it's a review article, okay, or it is a original research article, or it is an editorial, etc. Accordingly, the question sets will differ. Next, please. This is a clinical article question. Discussion of a clinical article varies based on why the article was selected. Some of these following questions, again, for the sake of time, I'm skipping all these. This can be circulated among all the participants. Next, please. These are the clinical article questions. Going to the next. And this is the research article review. Mostly we emphasize on the research articles, original research articles. There we can go by these questions, try to answer these, find answer of these questions from the article and discuss them. What is the research question? What is the purpose of the research study? Has the authors identified a conceptual model, framework, or theory for the research study? And if it is there, we can describe that. Literature review is comprehensive or current or not. Are major concepts related to research question and conceptual model, framework, theory identified and clearly defined? How did the researcher obtain a sample for the study? The sampling methods. Are the data collection points and strategies consistent with the stated purpose of research? That is, objective should match with the methods that are followed. Next, please. How did the researcher analyze the data? What kind of statistics has been applied? Were the methods appropriate to answer research questions? Are the findings, discussion, conclusions of the study study supported by data presented in the article? How strong is the study's level of evidence? Should the findings and conclusions be applied in our setting? If not, what work needs to be done further? This is about limitations and incompleteness, about conclusion. What resources and processes are needed to implement any proposed changes in your setting? If I have to do the same study in our setting, what should be done? What kind of resources and processes will be needed? These discussions should also be there. Next, please. So critical appraisal, basically journal club exercise or practice helps us to develop critical appraisal skills. Critical appraisal is defined as the process of systematically examining research evidence to assess its validity, results, and relevance before using it to inform a decision. And the critical appraisal tool should help guide the process. The different domains depending on the topic or the evidence-based medicine, this website will help us to develop the critical appraisal skill, would guide us. We can try to refer to this and try to see what's there. Next, please. So concluding remarks that a journal club is an integral part of doctors' continuing medical education. It's a step forward in evidence-based practice and needs to use surveys to assess goals and monitor satisfaction. Next. These are the references that I have used to develop this slide set. Next, that's it. I think. Thank you very much. So if there are questions or comments on this presentation, or else we can go to the more important two sessions of
No, Dr. Shantanu.
Yes.
I must.
Sir, there are some background sound is coming. Maulik sir. I think from the headphone there are some sound is coming, sir.
Okay. I will take out my headphone. Is it better?
Yes, sir. Now it's better, sir.
No, I must congratulate Dr. Shantanu because during my 30 years stay in All Institute of Medical Sciences and holding and chairing many journal clubs, I've never heard anybody telling us the details like this. And this is a learning experience for me. I'm very thankful for you. So I'm thankful that you have made this. I think this should be circulated to the young members of IPS who are in medical colleges and also the mid-career. This is my suggestion for you.
Thank you, sir. I think Dr. Shambo, you can take this advice and think about how to communicate this.
Yes, sir. Sir, actually, we are recording all our programs, and this will be actually transported to our website. So IPS West Bengal chapter, we have one website, so it will be uploaded there, sir.
Okay, great.
Thank you.
So, sir, with all of your permission, we have to move towards the first journal session. And
if Dr. Pal has any comment,
yeah,
Dr. Jyotirmoy Pal.
Professor Jyotirmoy Pal, sir, are you there, sir?
Yes, I'm there.
Yes, sir.
I congratulate for the program, and first let us start the discussion. Then we'll comment.
Okay, so may
Actually,
I request
Dr. Paul, your voice is not very clear. I don't know whether it is the problem
we
from
can
my
hear,
side.
We can hear, sir. We can hear.
Okay,
sir.
I think it is from my side.
So now may I request Dr. Saibal Das, who is a medical scientist at ICMR, Kolkata. Dr. Saibal Das is also a clinical pharmacologist. So over to Dr. Saibal Das and respected chairpersons for proceeding the first journal presentation.
No, before Dr. Saibal Das starts, I want to say one or two sentences on him, you know. After I retired from AIIMS in 2020, I joined as emeritus scientist in ICMR headquarters. There, I had an opportunity to be a member of the selection board of scientists D and E. I think last year or I think 2 years ago. there he was a candidate, you know. He was found to be an outstanding person by all the members from across the country, you know, because I never knew him before. And no one could say that he is lacking in his knowledge anywhere. And I think Dr. Saibal will be an asset for the Indian Pharmacology Society and the pharmacology for India. And I think Dr. Shantanu, I think he has worked with you also.
Yes. So I feel I feel so
and
proud
Jipal-
hearing this. Okay, great.
No, I feel proud. I told him in the morning that Saibal, look, in this journal club, I'm going to learn from you rather than teach you anything. So that is all I want to say about Saibal.
That's great.
Thank you, sir. Thank you for the very kind words, sir. Is my screen visible, Dr. Shambo?
Yes, screen is visible. You
I'll
have
make it
to
into full screen.
screen.
Yes. So at the outset, I would like to thank you, Professor Maulik, for the so kind words. I don't know whether I deserve this, but really it was so kind of you, sir. And Professor Tripathi, thank you so much for your role and contribution on shaping my career so far. It's been an enormous, and thanks for providing me this opportunity. Also, Professor Jyotirmoy, thanks for agreeing to chair this session, and Dr. Shambo as well for inviting me. So without further delay, we would like to go ahead to the presentation. This is a cohort study which has been published.
Your time is how much? Now we are facilitator, you know.
Yeah,
your time is?
Yes, so like around, as Dr. Shambo has mentioned, I will take around 15 minutes or so, and then we'll go to the discussion, sir.
So this is about 2:30.
Yeah.
So at 2:45, we will give you an alarm.
Right. Sure.
Okay.
So today we are going to present on this article, which is a successful 10-second one-legged stance performance predicts survival in middle-aged and older individuals. That is the study title. So the introduction is, as we know that with age and with progress, there is a progressive decline in the physical fitness and impairment in exercise and many changes in the body composition, etc. And sarcopenic obesity and loss of flexibility and balance are detrimental for the overall health, and these leads to frailty, fall, and other adverse sequelae. So unlike aerobic fitness, muscle strength and flexibility, balance, etc., these are preserved until the 6th decade of life, when comparatively it starts to diminish. So the knowledge gap for this study was that balance assessment, although it has been studied and proposed to be a clinical evaluation practice tool for a sufficient long period of time, but it has not been routinely incorporated in clinical examination. So does it even merit a routine clinical evaluation? And because one of the reasons was that there is a poor standardization and the technique of balancing, and paucity of data relating balance results related to clinical outcomes other than falls. And if we have a simple, inexpensive, and reliable and safe balance assessment tool, it will help us in our day-to-day clinical practice. So the ability to perform this task is a good prognostic indicator for certain outcomes, may it be a mortality. In this case, it might be useful as a complementary evaluation tool among middle-aged and older subjects. So with this background, the aim of this study was to assess whether the ability to complete a 10-second one-leg test was independently associated with all-cause mortality in middle-aged and older individuals. And secondly, whether the 10-second one-leg standing stance added any other relevant prognostic information beyond ordinary demographic, anthropometric, and clinical data. So it was a prospective cohort study using the data from the Clinimex exercise open cohort evaluation protocol, which is a long-standing cohort which has been established in the 1990s, and sorry, not 90s, I mean around 2000 kind of, and from there it has been followed up. So it included 1,702 participants aged 51 to 75 years at their first evaluation conducted between 2009 and 2020, and who voluntarily opted for the clinical evaluation of aerobic and non-aerobic physical fitness and obtained exercise counseling. And the data were collected and updated till mid-December, and censoring of the vital stats and mortality was censored till mid-December 2020. The demographic, anthropometric, and clinical variables were age, gender, date of evaluation, date of death, sensor data, and follow-up times were all available for all participants. The anthropometric measurements are obtained with participants barefoot and using minimal clothing and included height, weight, sum of 6 skin folds at 6 different areas, as well as BMI and waist-hip ratio. The clinical data were obtained regarding relevant diseases and or use of regular medications. Obesity was defined as a BMI of more than 30, and all participants were full ambulatory, and those presenting with unstable gait or signs of known acute vestibular or otoneurological disturbances were excluded. So this was the figure on the right hand side showed how this one leg stance test was actually performed. The participants were asked to stand on a platform, and the static balance was assessed by the ability to complete the 10-second test under close face-to-face supervision. So basically there was a person who was nearby to avoid any fall and related injuries. And to minimize the influence of muscle strength and flexibility and to improve the standardization, barefoot participants were instructed to place the dorsal part of the non-support foot on the back of the opposite leg as much as possible. And the elbow should be extended. The arms were naturally placed close to the body and instructed to fix the gaze horizontally at a 2-meter distance. And once the participant assumed the correct posture, a count of 10 seconds was started and 3 attempts were given to complete the test or not. So it was the outcome evaluation was very simple here. If the person was able to complete the test, maintaining the correct posture without any support, it was a yes, otherwise it was a no. The statistical analysis part, the Cochrane-Armitage test was used to test for temporal trends. Spearman rank correlation coefficients were used to calculate the associations, and with the certain variables, I will present that. And for the survival analysis, Kaplan-Meier curves are constructed and log rank tests were used to analyze the survival time. And for the survival analysis, only participants aged between 51 and 75 years were included in the mortality study, because individuals having age less than 51 and more than 75 were not included for this particular mortality prediction. And for every 5 years, the survival curves are calculated for every 5 years of age interval, basically like 41 to 45, 46 to 50, like that. So this was the result of the study, the demographic and clinical characteristics. So the second column here shows the total number of participants who were 1,702. And the next showed the individuals who could complete the test, and followed by those who could not complete the test. So yes and no. And next is the p-value. So if you see that for almost all of the outcomes, that is yes or no, there was a significant difference except for gender and except for the height. Except for gender, height, and patients with a history of myocardial infarction, all other individuals, there was a significant difference between those who could perform the test and those who could not perform the test. So in other words, it means that individuals who could not perform the test had a higher proportion of hypertension, dyslipidemia, diabetes, had a higher BMI, and all those things, so had a more unhealthier profile than those who could perform the test. So this was the characteristics of the participants. So then if we this is the graph showing on the y-axis, this is the proportion of participants completing the results. So is 100%, and this is the age group. So it included all individuals starting from 41 to 45 till 81 to 85, for whom the overall analysis was done, like 41 to 85 years age. So if you see, as age progresses, there were more no participants. So basically it means that younger participants could complete the test more frequently. On the other hand, the older participants could not complete the test, and near around the age of between like around 70, the proportion were almost similar. And as age progressed, so it obviously is more logical that as age progressed, there are problems in the balance and completion of the one-leg stance test. So the results were like there was no adverse medical events or accidents occurred. The inability to complete the test actually increased with aging, and the proportion of no responders was 4.7% among 51 to 55 years of age, and it increased to 36.8% to 66 to 70 years. So as I showed in the graph. So during a median follow-up of 7 years, the follow-up period was of 7 years. That is the median follow-up. Actually, the range was 4 to 9.41 years. 123 participants died, and mostly due to cancer, cardiovascular events, respiratory COVID-19 events, without any clear temporal trends in the death. And the study was sufficiently powered to detect a clinically important hazard ratio of 1.84. I will come to this in the subsequent slides. And the proportion of deaths in the no group was higher. So that is 17.5% of the people who have said no actually had died, vis-a-vis 4.6%, with an absolute difference of 12.9% to 9%. And as I mentioned, the no participants had an unhealthier profile, and a higher proportion of patients had dyslipidemia, coronary artery disease, etc. So with the exception of height, inability to complete the 10-second test was significantly associated with all other variables. So this is the Kaplan-Meier curve, probability survival of the participants. The blue represent those who could perform the test, and the red represents who could not, and the y-axis represents the probability of survival. And very obviously, the log-rank test shows the value of 85.57 with a significant p-value, meaning that more participants who had a no results had a higher chance of mortality for a follow-up time period up to 4,000 days, which comes to like roughly around 11 years or 12 years or so. So this is the mortality curve. And this is a correlation coefficient showing the correlation between different parameters, correlation between age, height, weight, BMI, waist tip ratio, and only 10-second wellness those who said no with age and no with waist tip ratio had a correlation, but that also our value was 0.4 and 0.26, which are also not much noteworthy. And then the association of the ability to complete the 10-second test was associated with the all-cause mortality, and it was found that when everything was unadjusted, the hazard ratio was 4.58. And please note the confidence interval was 3.21 to 6.53. And when it was adjusted only by age, it was 2.18. That means patients who could not complete the test had a 2.18 times higher chance of death during the follow-up period, with the confidence interval from 1.48 to 3.22, and which was quite significant. And when all the factors were adjusted, then like age, sex, BMI, and comorbidities, by comorbidity they meant coronary artery disease, arterial hypertension, dyslipidemia, diabetes. On all these factors are adjusted, the chance of mortality was 1.84 times higher than those who could perform the test. And again, the confidence interval was from 1.22 to 2.77, and it was significant. So, and also they have included the C index, the Harrell C index, which actually performed better. We have Professor Moitro as our expert in the statistics. He will deal more with this. He will throw more light on the statistical techniques and the sacrosanct nature of this test involved. I'm not going to much details. But still, when all these factors are incorporated, the C index was improved, and the continuous net reclassification indices NRI and IDI were also better to say that the additive value of inability to complete the test was having an association with the mortality or not. And this was the DAG curve showing the associations between BMI, age, sex, vital statistics, and the 10-second OLS. So I won't go much into the discussion, rather let's go to more into the critical appraisal part of this study. So one of the strengths was that the 10-second OLS test was carried out in a well-controlled situations, and it was easy to explain to the participant, and the median follow-up time and the percentage of death provided appropriate statistical power. So for the hazard ratio 1.84, there was a significant or a sufficient statistical power to say this. And there were data available from several anthropometric and clinical variables that were used for the multivariate regression model. So the authors concluded that the inability to complete that test in middle-aged and older participants is related to a higher risk of all-cause mortality and consequently to a shorter life expectancy. This was the conclusion. So now let us go to the critical appraisal of this article. It was a very good, well-designed study which came in the many news feed, even in the big media as the news feed came, and it was very well designed study. As a clinical pharmacologist or as clinicians and or the physicians, we need to understand the merits of the study in light of our day-to-day existing practice. And in doing so, we will do the critical appraisal of this study. And please note that this is not a fault finding exercise, that what the authors did not do, or we will rather appraise the good things in this study and say what others could have been done, or what are the other concerns. So I have felt that the checklist given in this book published by the Journal of American Medical Association, JAMA Evidence, Users Guides to the Medical Literature, it gives the guidelines of critical appraisal of different kinds of studies, starting from RCT cohort. Even for a cohort study, this is a prognostic study, and it has a separate checklist to evaluate. And even the critical appraisal skills program, the CASP, also gives the checklist which we should which we can follow. And please note that these are not the reporting checklist like we have STROBE for the observational study. Those are mostly for the reporting or when the authors want to publish the study. We'll be using these scientific appraisal tools rather, and I have actually amalgamated the questions and the points which are present in the JAMA CNSP as well as other articles, how to appraise a prognostic study, and have integrated. I have also integrated the Newcastle-Otaya tool for evaluation of the risk of bias for the cohort study. So let us see, in light of the questions which has coming up based on this checklist and our insights and our knowledge, how this article stands. So the first thing we need to understand, are the results of the study valid, and how serious is the risk of bias? And this also encompasses the methodological robustness of this study. So did the study address a clearly focused issue? Yes, it did. It has a well-defined objective. So was the cohort recruited in an acceptable way? So this was a prospective cohort study using data from the Clinimex exercise open cohort evaluation protocol. Unfortunately, I could not retrieve the full data from the supplementary text about the details of the cohort, but it was a standardized cohort, and there are other publications also from this cohort which are also done on exercise. I will also show those. Next, was the sample of patients in a study representative? Now, some of the issues here which I pointed were also pointed out by the authors in the limitations, but I have supplemented this with other points as well. Now, in this particular study, the authors have included participants of white race and belonging to the higher socioeconomic strata in Brazil. And we know there are ample amount of literature which shows that geography, race, ethnicity, physical activity, then racial ethnic differences, etc., which actually can impair the physical ability and the endurance, all these things which also can affect the balance. So because of the race, ethnicity wise differences which can lead to differences in the physical activity, which again can be differ based on the socioeconomic strata. So all these factors can actually lead to a bias in the patient or the participant representation. Next, were the patients classified into prognostically similar groups? Well, there was no initial classification, so it was a single cohort which was followed up. Some patients could not do the test and some could do the test. However, the distribution of the major underlying causes of death did not differ between the two groups, and there was no clear temporal trend of any particular death. So this means that the proportion of individual causes of death were equal and non-significantly different between the two groups. Was the exposure accurately measured to minimize bias? All participants underwent actually similar test procedure. So it was a well-structured and standardized process. Then was the outcome measured, accurately measured? Yes, a standardized protocol was followed. However, please note a dichotomous outcome was followed. Obviously, for this type of test, there is a dichotomous outcome, like an yes-no outcome was followed, without any data being given till a distribution of, it was a 10-second test. How many patients could not complete the test? For example, 9 seconds somebody dropped out, and vis-a-vis somebody dropped out at 11 seconds. But it would be counted as no and yes respectively. But this makes the studies being, there is a chance of a study being some fragile. Like if 1 second difference could have cause more participants to go to the other group, the fragility of this study could have increased. So also the data on the validity of this test is needed, whether this 10 second is perfect or we need maybe 15 seconds, or the author have given 3 times chance for every participant. Why 3 and not 5? So this data is also important. There are other better indexes also, but one leg stance test is also being reported in the literature. Several confounding factors were identified, but several were missed out, like occupation. There is a study which shows there is a postural stability difference between musicians and non-musicians. Drug was something, that is medication related fall among elderly, which is very, very common, drug related fall. So different diet, exercise, and pattern of exercise can lead to these differences. So these things were left out. Have they account of the confounding factors in the design analysis? Yes, the confounding factors were included, but however, there was no sensitivity analysis was performed, and no subgroup analysis was also performed based apart from age, whether each particular comorbidity or each particular other confounding factors like an exercise status or disease status, etc., could have impacted the outcome or not. It was a wholesome picture was given. Was the follow-up subjects complete enough? Yes, it was complete, and the loss to follow-up was minimal, and a 7 years follow-up was done. But in a similar study which has been published in JAMA, the follow-up was almost 13 years, where the median follow-up of this study was 7 years. Next, once we are satisfied with the methodology, then we will go to the results. So what was the results of the study? It was the results we have discussed, it was explained. However, the author have given an overall hazard ratio. Now, this could be misleading because hazard ratio represents the instantaneous risk over the study period, time period. Now, somebody having an age of 50 vis-a-vis somebody having an age of 70, if I say both have the risk 1.84 of the chance of dying more than those who could not complete the test, even after adjusted for age, this might lead to a confusion, because we know that in a higher age group the chance of survival may automatically reduce. So providing an overall hazard ratio without taking into consideration the time varying confounding, because here we have to understand that the frailty, age, this factor is progressing, and this is slowly progressing this is a dynamic thing, and this can actually this is impacting on the mortality, and this factor is not a stagnant factor. So without considering this dynamic factor, if we consider only an instantaneous risk for an entire period of time, this might lead to a confusion. How precise was the results? Well, it is being defined by the confidence interval. In certain cases, for the unadjusted hazard ratio, was confidence interval was little wide, although the number of sample size was more than 1,700. Then, do you believe the results? Yes, we believe there are certain other factors, certain other similar papers are also there, but the findings has to be also explained by a biological plausibility. Otherwise, association studies do not make sense, because we need to know the association. What is the biological association of how balance is being impacted due to heterogeneous factors among a particular cohort? Also, is it subjected to intervention, or is it the disease process itself is causing certain damage? Because we have seen that the no participants had a higher mortality and unhealthy lifestyle, etc., than the other. So is that impacting the balance, and that is leading to the fall? So a little bit of a chicken and egg problem is coming here. So the biological plausibility needs to be carefully addressed. Now they have, regarding the stats part, Professor Moitro is there, but just they have used NRI and IDI. These are complicated advanced statistics, but these assume a non-Gaussian sampling distribution, and in logistic models study published in epidemiology has shown that they behave poorly, and sometimes these non-informative predictors often comes out with a positive score. So this we have to take this result with a pinch of salt here. So the last part of the critical appraisal is, can the results be applied to the local population? Well, we have mentioned that this needs to be validated in the local population, because race, ethnicity, dietary factors, prevalence of the disease, even life expectancy, etc., socioeconomic status can cause physical differences in physical fitness and hence in the balance, and this needs to be validated in the population. Do the results of this study fit with other available evidence? Yes, there are similar other studies. And what are the implications for this study for practice? So the authors have recommended that this is very simple, inexpensive, easy technique which can be which can be utilized in a routine day-to-day practice in a clinical examination. But before that, we need some even more data. And the same research group actually has published similar other studies: ability to sit and rise from the floor as a predictor of mortality, exercise heart rate gradient as a predictor of mortality, cardiorespiratory optimal point during exercise as a cause of mortality. Now, these are maybe linked together. So which particular test, clinical examination we need to take and which not to take needs more validation results in a wider population in a more robust clinical setting before universally adopting in routine clinical practice. So with this, I come to the end of my presentation. Thank you so much for giving this opportunity. And as Professor Tripathi has mentioned, that it's an interactive session and it is a great opportunity for me to learn as well from the respected experts here as well as from all the participants. Thank you so much.
Okay, Professor Paul, would you like to say something, Dr. Jyotirmoy? Do you have any questions from the audience before the presentations? It was circulated, no?
Yes, sir. So actually there is no question to the presenter. So actually we are collecting some responses from them, and
yeah, we are getting some. Yeah.
So I am requesting everyone to put the questions in the chat box.
So I can't find Professor Jyotirmoy Pal. So can I say something about it? First, I must congratulate Saibal for nicely presenting this very interesting article, because this article, when Dr. Shantanu asked me which one to choose, I think Dr. Shantanu, I didn't take much time to choose this one. Why? Because as a table of content alert, it came to me a couple of weeks ago, and I found it is very interesting, you know, although I didn't go through it. So I chose this one. So I think your critical appraisal part is very interesting and will address many of the questions. My one single question is that as far as the patient inclusion and exclusion criteria, there you have identified certain lacunae. But do you think that musculoskeletal problems could have been excluded, because that is a major factor in allowing the patient or person to stand one-footed? That I couldn't find anywhere. Of course, you have mentioned the use of medicine. That is an important confounder in this case. Now, I want to say before you said that generalizability is an issue across various ethnic diversities across the world. That is a big question and rightly pointed out by you. But suppose if you intervene the poor performers, it is you said in JAMA there's 13-year follow-up. Here it is a mean follow-up of 7 years. Suppose we start intervening, if they are not intervened, in the absence of modifiable risk factors or presence of modifiable risk factors of cardiovascular disease, suppose we repeat the dose or repeat the test after a year or so after intervention or every year, would it show any sort of this thing that this is a valid test, that previously the person could stand this many seconds, or this was the performance and this is improved over time after do you think so?
Yeah, thank you, sir. This is a very interesting aspect, and actually the authors themselves have also identified this issue, that this was tested at one single time point, and all the participants had certain medical issues, some of which were interventionable, like cardiovascular disease, which had modified the risk factors. But since this was not repeated, so the time varying relationship was not established, and this was a declared limitation in the study itself, that it was done
Okay,
at one
that can be
single
done.
time point.
We have one
Yes.
question from one Dr. Puneet. Can you say that the data for 55 to 56, you can see that, or 60
Yes.
to 60 years are also missing? What is your comment on that?
Yes, so let me show the slide. So for the mortality, they have taken the patient from 45 years. They have checked the mortality. So, but they have included the mortality data from 45 years. So that is actually taken care in the survival analysis. And even for this thing, for the inability to do the test and with the participants' results, the age ranged from 41 to 85. So both the age limits, both the mentioned age were actually included. Then
There
Dr.
is another
Rupesh also,
comment.
yes,
You can
title
see
of the,
Rupesh Warve.
yes,
The
yes.
title of the article is not self-explanatory. Do you think that is a major fault or major mistake on the part of the authors or the journal reviewers that they have not highlighted? Do you agree with this comment?
Yes, that title seems to be ambitious. If we go by the Strobe statement about the title, that it also says that the study design has to be there in the either in the title or in the abstract at least, and title has to be conclusive. I mean, yes, it seems to be for more ambitious title without going into the details of the study design that was employed. So actually, people can be biased and feel that this is a very effective test which can as a 10-second predictor of a mortality kind of test, but that has to be read with caution. Agree.
I cannot find any more comments in the chat box, but still I think people are thinking about it, and I think there are youngsters, I mean to say that, who are freshly graduated or post-graduated or doing DM, or they are mid-career faculty members who are also in this group. So for them, would you like to highlight certain points, how to design a study, what was the research hypothesis, how they have made the primary objectives, and linked to that, what are the primary outcome measures, secondary objectives. These certain points might be. Professor Paul is here. Dr. Paul, would you like to say something on his presentation, please?
I want to ask one question. This test we use in a particularly geriatric population to understand is the balance capacity as a tool for the static balance test, and their cutoff value is only 5 seconds. If it is below 5 seconds, chance of fall is more. If it is more 5 seconds, anyhow you have taken the 10 cutoff, and your objective was not the fall. Your objective was more for the outcome of mortality from different disease, from CVD or stroke or like this AMI, whatever may be. So just I want to understand the balance test, whether the population you have taken in the two groups, what is the evenly distributed?
Yes, I mean, the population, it was taken from a existing Clinimex cohort, and but there were higher frequency of individuals having unhealthy lifestyle, as well as higher BMI, higher frequency of cardiovascular risks and dyslipidemia, even higher in proportion of diabetics. Now diabetics themselves has autonomic dysfunction that may lead to postural instability. So those factors are there. So they want to say that yes, it is something which is a disease itself which is finally causing the gait instability, and if you actually do this test in a routine clinical practice investing 10 seconds, it like you check for a heart rate and the BP, it can give an independent predictor of the mortality. So it is the disease process itself which is actually leading to this postural instability, that biological plausibility is there, but that has not been established yet. So this is being used as a tool to test. So this population, the two groups, which initially it was a one single cohort, so it was not a two cohort that we can actually test the comparability. Before we go to the comparability outcome, the single cohort, somebody could do, somebody could not do. Those who could not do had a higher frequency of these diseases, which is obviously understandable, and that had led to the postural imbalance.
Yes, very good. The take-home message for the practitioners, for
Yes.
physicians who are attended this group, the message is, if you go through the fall chapter of geriatric any textbook of medicine, fall is should never be considered as a simple fall. Fall due to some aging process. Particularly, fall should be taken very cautiously in the geriatric population, particularly if there is a two fall in the last 6 months. That is called recurrent fall. If there is recurrent fall, don't consider that this is the aging process of some vision abnormality. Always think there is some background disease that can be from the efferent system, suppose neurological peripheral nervous system or eyes or ear, or the central processing system, brain and other heart, lung and others, or effector system. Effector system is musculoskeletal system. So any defect in any of these three systems lead to the recurrent fall, and recurrent fall definitely is a significant issue in elderly population and should undergo in-depth analysis. Don't consider, just leave it as such. Go for in-depth analysis. Another red flag sign is if there is two fall in last 1 month. There is a red flag sign. Those patients should be very cautiously and preferably should be investigated keeping in hospital. So recurrent fall, two fall in 6 months, go for investigation. Two fall in last 1 month, very serious issue, red flag sign, go preferably for admission and go for in-depth analysis. This is the Edinburgh protocol for the fall assessment. Very good assessment. You have taken the 10 second, possibly because you have taken some younger population from 51. That may be the reason why you have taken the cutoff 10. Usually we take the 5 seconds when you take the population above 65. Thank you.
There is a question, sir, from Dr. Praveen. As there are many causes of mortality, how much of this test has contributed? This has not been answered. Well, this test has no cause relation factor with the mortality. It is the outcome having that. But yes, I can understand. So actually, if you see, they have given that there was, they have compared the distribution of the causes of death between the yes and no, and the p-value was 0.45, which was not significant. So essentially, what they meant to say is that if the causes of death were similar, of course the numbers were higher, but if you see the proportion, the causes of death were similar between the two groups, which again says that that was also counted, and the representativeness of the cohort. So that was actually looked by the authors themselves. But thanks for this question. So Dr. Santosh,
So
can you
what about that? The next question. Can you understand that we can use 10 second standing? That is a very big question, because we are too early to decide on it. I was going to ask Professor Pal that I don't know how to take it, because would you like to have this test in his clinic for patients? Ask them, I don't know, because there are various factors. A patient coming from a very humid condition to his clinic and without rest, where how much they can. So there are certain factors which can influence. It's too early to say that you can use this test in your clinic and tell the patient that you run a higher risk of cardiovascular mortality. It is too early. What do you say, Dr. Paul and I think Saibal, for this question? Can you understand this test as a clinic?
How this can be used in the clinics?
Yeah, that is the point.
Assessment of the cardiovascular mortality. Sir, regarding whatever in geriatric population, we used this test for basically the neuro disease of the neurological system and the effector system, not for the cardiovascular system. But this study has shown that it can be used, but in clinically we do not use the geriatric population to assess the cardiovascular mortality. Basically, we use the test for the neurological system and musculoskeletal instability.
And sir, because you have mentioned, you mentioned about this neurological, this JAMA article mentions that one leg stance is a more crude test and Romberg test is much better even to pick up the vestibular insufficiency. But here the authors have actually excluded patients with vestibular disorder. So regarding the inter-rater agreement among the results of this test, that can be also a potential research question.
But that takes me to my next question. What is the mechanistic hypothesis of a 10-minute one-leg standing, that if the person fails to stand for 10 seconds, and for why does she or he run a higher risk of cardiovascular mortality rather than neurological as identified by Dr. Paul? What is the mechanistic link between these two things?
I think this is the most vital question in this thing, that what could be the reason actually? What is the rationale? When you think of this 10-minute one leg stance, that what is the hypothesis and what is the pathophysiological basis or physiological basis of this? That one leg 10 second stance, one leg stance. So have you also done some literature search, Dr. Saibal, on this?
Regarding this biological plausibility. So patients who are having autonomic dysfunction, because a subsequent number of patients were having diabetes, so those leading to have autonomic dysfunction could be attributable to the poor performance in the one leg stance, and then with increased age, frailty, those aerobic performance may diminish. Those can be the reason, but exact pathophysiology or the biological means the pathway, I'm not sure about.
When they talk about this test, I think they are trying to investigate whether this test can be an independent test. Whether you have background diabetes or background hypertension, etc., or autonomic dysfunction, etc. That's a different issue. Those who will have, they will have less balance, etc. But then, if, say for instance, from 45 years, otherwise there is no comorbidity, there is no morbidity, okay? Whether if you keep on following this, whether you can think of this test as a predictor of okay, cardiovascular mortality. Those who are able to stand, we have a lesser risk as compared to those who cannot complete this 10 second. They are at a higher risk. They are trying to actually establish this. And I think a lot of questions remain unanswered through this particular article, and this needs to be the similar kind of investigation should be repeated rather. Whether another group, they are also doing similar kind of prospective study to see whether it has any value. That needs also validation, I think.
Absolutely, sir. Absolutely, this validation is important, sir.
Saibal, are you looking at the questions in the chat box?
Yes, sir.
One more question is there: how to make a study to use this
as a diagnostic marker, and there is a certain difference between this diagnostic study and a prognostic study. If we have a diagnostic study, then we compare with the gold standard diagnostic test and find the sensitivity and specificity, positive predictive value and all. But here actually it's a prognostic study, and this gives the chance of mortality. Is not that when you go for a diagnostic study, it says here it's yes no, versus in a gold standard it's an yes no, and see how much, what is the sensitivity. But
I think the person who has posed this question, probably he meant a prognostic marker. Inadvertently has made a diagnostic. It cannot be a diagnostic marker. He has meant it is a prognostic marker. So if you consider, instead of diagnostic, if you read a prognostic, then how to make a study to use this as a prognostic marker.
So it is exactly the same thing which the author have done, that as an independent prognostic marker for the mortality. But as Professor Tripathi also mentioned, this needs to be validated in a bigger cohort, in a different representative participant and prospective study for a longer follow-up, and we need to have that robust data before routinely implementing or using it as a prognostic marker even. I mean, from this study it looks there is sufficient ground for looking it to be convincing, but this needs to be repeated and in a bigger cohort and in different population as well.
at least as of now, we can say this study has actually flagged a very important question, and it has successfully established a new hypothesis, and that hypothesis is now needs to be tested prospectively.
And it was well powered to report this outcome.
Right.
So can we end this journal club here? For interest of time, I think statistics part will be dealt with Professor Maitra in greater more details at the end.
Yes.
So can we thank Dr. Saibal or any other?
Yes, of course.
Yes, sir. Also, Dr. Moitro had another meeting from 4, so we have to be a little bit in hurry.
Thank you so much, sir.
So
Thank
we
you so
can
much.
end this session now. Over to you for the next session.
Thank you so much, everyone, for giving me this opportunity.
Thank you.
Thank you.
Thank you, Professor Maulik, Professor Jyotirmoy Pal, and Dr. Saibal for giving us your valuable time. And now we are moving to our next session. And to chair the session, may I invite Professor Sudip Kumar Ghosh, who is a noted dermatologist in the country, and he is the professor and head of Department of Dermatology at Araujo Medical College. And welcome, sir. And also may I invite Professor Shantanu Kumar Tripathi, sir, to chair this session. We all know, sir. So over to our chairpersons before we proceed for the second journal presentation. Sir, shall I start, sir? Tripathi, sir?
Yes, you can. You can, please.
Sudip, sir, shall I start or you have any comments, sir?
Dr. Sudip, please, you can have some introductory comments, and then Dr. Shambo can start.
Introduce the subject, that is atopic dermatitis. It's a chronic or chronically relapsing disorder with major features of pruritus. So by that, which elicits the desire to scratch. The dermatitis in the form of vesiculation and oozing. It may be subacute dermatitis in the form of scaling and dryness, or there may be chronic features of dermatitis in the form of lichenification, that is thickening of the skin, hyperpigmentation, and accentuation of the normal skin markings. So typical morphology, identification of typical morphology is very important, and there are some age-specific patterns, particularly regarding the distribution. So you have to look for facial and extensor involvement in case of infancy, and flexural involvement and lichenification in case of children and adults. So the commonly associated features with atopic dermatitis are personal and family history of atopy, that is history of allergic rhinitis, history of asthma, and history of atopic dermatitis. And there is xerosis and skin barrier dysfunction, that is very important and key feature of atopic dermatitis. And there is a immunoglobulin E hyperreactivity. And before going into the discussion about the drug trial in a patient with atopic dermatitis, we have to know a little bit about the pathogenesis of atopic dermatitis. So initially, there is barrier dysfunction that occurs in the setting of atopic dermatitis. There is filaggrin deficiency, ceramide deficiency, and overactivation of epidermal proteases. On the other hand, regarding the immunological factors, there is a complex interaction between the T cells, dendritic cells, innate lymphoid cells, mast cells, and eosinophils. And certainly, there are some environmental factors regarding the microbial exposure, climatic factors, and smoking habit, and also skin pH. So there is a complex interaction between the barrier dysfunction, environmental factors, and pruritus. There is activation of the Th2 cells and Th17 cells. There is complex interaction between the interleukins, particularly interleukin 4, interleukin 13, eosinophils, mast cells, and Treg cells. So several immunological factors, barrier dysfunction, environmental factors, and pruritus leads to the complex clinical picture of atopic dermatitis. So with this background, I will ask Dr. Samajdar to start this discussion.
Thank you, sir. Thank you very much. So today we are going to discuss about this journal, which is published in NEGM in 2021. So this is actually a report of a sponsored, Pfizer-sponsored trial on Abrocitinib. So as we are discussing, and Sudeep sir has mentioned a little bit of background, but when for next maybe 10 or 15 minutes like that, we are going to dissect this journal in these following points. Number one, what is the research question? Then we'll little bit discuss on study design and whether how much it is suitable, and whether the results of the study are acceptable in our context, and we'll have some critical comments. And this will be a learning agenda for me, because as a journal club presenter, it is also a privilege of the presenter that he also get enough knowledge from the delegates, from the listeners. So with that, as Professor Sudeep Ghosh sir has mentioned, that atopic dermatitis, which is a skin barrier dysfunction due to different immune dysregulation, filaggrin mutations, and skin dysbiosis, there will be increased activation of Th2. So what happened actually when the allergen enters through this dysfunctional skin barrier system? They are taken up by the antigen presenting cell, and antigen presenting cell will take that particular antigen or allergen to the T knife cells, Th0 cells. So now the Th0 cells, after the signal 3, they will produce some specific cytokines like interleukin 4, interleukin 13. And this interleukin 4 and interleukin 13 actually promotes from Th0 to Th1 conversion, sorry, Th2 conversion. And what happened then? This Th2 conversion leads to teach the B cells to produce more and more IgE instead of IgG. So there will be a class switching. And ultimately what happened? That IgE will go and sit on top of mast cells. And when again there will be a re-entrance of allergen, that allergen will sit on that IgE, which is seated on the Fc epsilon receptor over mast cell. They are coupled, and ultimately mast cell will be degranulate, and there will be release of mast cell related mediators, and there will be symptoms of like itching, as sir has mentioned. So what is very important, that there are, due to this increased activation of Th2, there will be more cytokines like interleukin 25, interleukin 33, along with the classical IL-4, IL-13, which are the very much common features of type 1 hypersensitivity. But what happened specifically to this atopic dermatitis, in chronic cases, there will be Th1 and Th17 activation too. And as we all know that Th1 is responsible for IL-12 and interferon gamma production, and Th7 is responsible for IL-17 and IL-22 production. There is something which is very much important, extra IL-4 or IL-13 targeting. So for that, we need something which can target those areas too. And as we had discussed, there is a upregulation of epidermal chemokines, pro-inflammatory cytokines, and different angiogenic factors, and with a downregulation of antimicrobial peptides and factor responsible for skin barrier function, they actually induced all those cytokine mediated JAK-STAT pathway. And apart from that, Th2 cytokines, which is mostly responsible for JAK1 and JAK3 activation, whereas the inhibition of JAK2 or rather JAK2 is very important for our hemolytic system or hematopoietic system, because if we inhibit JAK2, so there could be chance of development of neutropenia, anemia, or there will be more chance of thrombosis. So what happened? We need something which is very specific for JAK1 inhibition, and for that this molecule, novel molecule, they had a target on specific to JAK1, which ultimately leads to the inhibition of different IL-4, IL-13 mediated reactions. Also, not only that, but the IL-22 mediated reactions and IL-12 mediated reactions, which are the cross product of our final product of Th1 and Th17 mediated reaction, that also can be addressed with this molecule. With that, the specific research questions for this particular trial was whether the Abrocitinib 200 milligram once daily, Abrocitinib 100 milligram once daily, then Dupilumab 600 milligram stat followed by 300 milligram 2-week interval, and placebo, how they are going to give impact on IgA response and EASI 75 response. So these two are the primary outcome. So what was that? The primary objective was to check how the IgA response, that means investigator global response, they are, if there is more than 2 points improvement from the baseline, so that is taken outcome. And also in case of EASI 75 response, if it is more than equal to 75% improvement from the baseline at 12 weeks, then considered to be a primary objective response, primary outcome response. So there are some secondary objectives, like each response as taken as a scale, pruritus scale, NRS scale, and that was taken from the 4-point improvement from the baseline at 2nd week. And finally, another IgA and EASI 75 response was taken at 16th week. So as this study was a phase 3 double-blind, double-dummy trial, so it was randomly assigned from 2:2:2:2:1. One means the placebo, so Abrocitinib arms 2, Abrocitinib dosage form 2:2, and another was Dupilumab. So when who are the subjects? The inclusion criteria was more than 18 years, at least 1 year atopic dermatitis, moderate to severe, where more than 3 IgA score improvement. There should be a more than equal to 3 IgA in the inclusion criteria, and EASI score should be more than 16, more than 10% body surface area involvement, and at least more than 4 score in the PP-NRS scale. So primary analysis was done as a modified intention to treat analysis, though the primary endpoints were prepared as a superiority design, whereas the secondary endpoints were prepared as a non-inferiority design. And before that, there was a 28-day screening period. Systemic and topical medications for atopic dermatitis was discontinued before the first dose of the trial medication or placebo was administered. Only the emollients twice daily, that was initiated 7 days before. Topical therapies, low or medium potency, topical glucocorticoids, topical calcineurin inhibitors, or topical PDA4 inhibitors were used. So here I think they had not done here. We need to little bit know about this platform trial design, because as there are different interventions that could be used, so we can have this type of platform trial design in this type of study population. And for explanation of this platform trial design, at the end of my presentation, I will ask my professor, my mentor, Shantanu Kumar Tripathi sir, to throw some light. So as we are analyzing the result of this particular study and the primary endpoints, what we found that yes, the Abrocitinib 200, 100 and both Dupilumab, they have statistically significant improvement in the IgA response at 12 weeks and ESFI5 response at 12 weeks. But they are not the difference was not statistically significant between Abrocitinib versus Dupilumab in the primary endpoint. And when we are talking about secondary outcome, and there was a place where the scoring, the pruritus scoring was measured, there it was found at 2 weeks there was a superiority in terms of better benefits in favor of Abrocitinib compared to Dupilumab. So here we can see here, but for a long time when it was 16 weeks, that was not there. The superiority was not there in terms of each response. And here we can see when there is a 2-week each response, there is a statistical significant difference with Dupilumab in favor of Abrocitinib 200 milligram, not 100 milligram. But at 16 weeks, the difference was not there with Dupilumab. And there were some side effects like nausea or acne, some less severe cases of herpes zoster and thrombocytopenia with this Abrocitinib arm. So when we are having some critical comments to this particular article, first of all, we need to see it like that, the randomization procedure. In this particular article, how they actually randomized the groups, that was mentioned, but how it was the allocation concealment was done or not, that was not mentioned. And when they are comparing a drug, active comparator like Dupilumab, generally they took a 2 weeks response when in a comparison. But when all the studies done with Dupilumab previously, they were actually showing that Dupilumab is effective after 16 weeks. So and also if we go by the US FDA document for development of drugs for atopic dermatitis, there they had clearly mentioned for any drug to be used in atopic dermatitis for their trial, the safety evaluation can be done at 2 weeks, 4 weeks, 6 weeks, 10 weeks. But for efficacy evaluation, the minimum duration of that particular drug should be 12 to 16 weeks. So again, as in the secondary outcome they are showing, and in the conclusion they are also mentioning in the terms of each response, this new molecule, the Abrocitinib, is superior to Dupilumab. So we need to accept that comment with some pinch of salt. Next is they had used the modified intention to treat analysis. So we all know when we are talking about intention to treat analysis, that means once randomized, we need to analyze all. So there should not be any exclusion. But for MIDT analysis, there is an advantage for maybe for the sponsors or the investigators, they can omit some subjects by some undefined criteria. So it is very important to have a particular flowchart for analyzing one article to check whether the MIDT analysis was done, the exclusion or inclusion of the patients were to be analyzed were done in a correct manner. That is not there in this particular article. And another is in the secondary outcome, they had mentioned as a secondary outcome, they took that 2 weeks each response, but in the conclusion, they had mentioned it as a Abrocitinib 200 milligram is superior to Dupilumab in terms of each response at 2 weeks. but whether when they are analyzing the secondary outcome in a predefined non-inferiority trial design mode, so whether it is okay or not, that to conclude like that this drug is superior to another drug. So this is some critical comments, and when we are having our critical appraisal for a clinical trial, we need to follow one tool we have, that is CASP tools for clinical trials. So that has some specific questions. First of all, did the trial address a clearly focused issue? Yes, this trial addressed a clearly focused issue of atopic dermatitis, and they had make clearly in terms of intervention, comparator events, population studied, and outcome considered. Obviously, in the title, that was not there. The PICOT form is not there in the title, but that can be acceptable sometimes, and many articles now published in this way. So was the assignments of the patients to treatment randomized? So here the question is, was the allocation sequence concealed from the researchers and patients? That was not clearly mentioned, how the allocation concealment was done and how this was carried out, how the randomization was carried out. So again, where all of the patients who entered the trial properly accounted at its conclusion. So here we need to analyze where the patients analyzed in the groups to which they were randomized, all those patients were not analyzed because of that MITT analysis. Next question is, was the trial stopped early? No, there was not. The trial was not stopped early. There was no provision of interim analysis in this particular trial, and it was not done. So were patients, health workers, and study personnel blind to treatment? Yes, they were blind, and as Dupilumab is an injectable formulation and Abrocitinib was a oral formulation, they also used that double dummy method for blinding. Were the groups similar at the start of the trial? Again, there is one question, because in the baseline characteristics, which is very important, what are the drugs used for atopic dermatitis? Specifically, we all know there is an impact of using steroids. Those they are mentioning that low intensity or medium intensity corticosteroids ointments were used, but we don't know how much they are balanced in 2 groups, or rather 4 groups. So that is not there. How much the therapeutics distribution was there in each group, how the immunosuppressants were used in each group, that was missing from this report. And aside from the experimental intervention, where the groups treated equally, yes, that was already we had mentioned, that was not given in a tabular form. It is basically needed for baseline characteristics should be matched between all the groups. So how large was the treatment effect? That was again the another questions. And is the primary outcome clearly specified? Yes, they had clearly specified the primary outcome. What outcomes were measured? Again, that was clearly mentioned, and what results found for each outcome. So that was mentioned. But how large was the treatment effect? Again, that was given in the predefined way. So these are actually there in this particular article. How precise was the estimate of the treatment effect, and what are the confidence limits, how they differ? These all are actually covered. The patients covered by the trial are similar enough to the patients to whom you will apply. So that questions the external validity of the trial. But yes, we all know when we are talking about a randomized control trial, we always say the internal validity is much more than the external validity. But there are a good representation from actual atopic dermatitis patients in this particular trial. can the results be applied to the local population in your context? That means in this particular trial, they were included Asian populations too, and though the data was not there in this particular journal, how much percentage of Asian populations are there, but yes, the Asian populations were included. Were all clinically important outcomes considered? Are the benefits worth the harms and cost? One of the major important issue that the therapeutics, that is Dupilumab, as they are comparing with Dupilumab. So I think this is considered, but it is not always possible for a phase 3 clinical trial to consider all those elements. So with that, I thank you all. Now, may I request Professor Shantanu Kumar Tripathi sir and Professor Sudeep Ghosh sir for their expert opinions.
Yes, Dr. Shambo, you have very nicely made the presentation and did the critical appraisal also. You are right. You have mentioned about the comparing formulations being of different dosage forms, like one was oral and the other is injectable, and that's the reason why they have used the double dummy technique. But what was the formulation for placebo? Whether the placebo, I think whether it is mentioned in the protocol in the paper or not, I don't know. But ideally, the placebo should also match with either of them in a double dummy. So there should be a placebo for the oral and a placebo for the injectable. So then only it is done. Otherwise, there has to be also people who are conducting the study at the site. Some of them will be blinded and some other will not be blinded. Unblinded study personnel at the site who will actually be responsible for administration of the drug, where the proper matching placebo, identifying the matching placebo is difficult. So I suppose in this case, the placebo for both oral and the injectable was available, and that's the reason why they called it a double dummy. Regarding the allocation concealment that you have pointed out, particularly because double dummy has been used, so that takes care of the allocation concealment. Okay, I don't think there should be an issue in that regard. But otherwise, you have also used a standard tool for critical appraisal for a clinical trial in this case, and quite nicely you have covered. I think I can leave at this point and invite the opinion of my co-chair, Dr. Sudeep Ghosh. At the same time, I would request that the organizers or the host can also unmute Dr. Ravindran, who is possibly waiting, and so that he can also come up and give his opinion. Okay, Dr. Ravi, please. You can also give your opinion, and if you have heard this particular article. So Dr. Ravindran is also there for giving his opinion. Let me introduce Dr. Ravindran. Dr. Ravindran is a very senior pharmacologist and very erudite pharmacologist. He is the editor of a pharmacology journal, very respected pharmacology journal in the country, and very senior scientist and very astute critical person. We are happy to have Dr. Ravindran here. So besides Dr. Sudeep Ghosh, who is the chair, who is a dermatologist, senior dermatology professor, and Dr. Ravindran is here, both of us we are privileged. So I'll request Dr. Sudeep to give some opinion, give some opportunity to Dr. Ravindran to say a couple of words, and then Dr. Sudeep can take over. Dr. Ravindran, please. Dr. Ravindran is heading the Department of Pharmacology at JIPMER.
Okay, yes. Thank you, Shantanu, for your kind words. Well, I have nothing to say. Well, I joined from the beginning and then I'm enjoying now Saibal presented. In fact, I wanted to ask a question, but then now I can ask in the next session. Okay, right. Thank you. Thank you. We can continue with the discussion.
Okay, Professor Sudeep, please. Professor Ghosh.
So Dr. Shambo has nicely covered each and every aspect. And regarding the treatment, new drugs are coming in the pipeline. So it's a good sign because atopic dermatitis has very limited number of drugs in the form of systemic steroid, cyclosporine, some antimetabolites, and sometimes omalizumab has also been tried. Some probiotics, Chinese herbal, oral vitamin D, all are part of the treatment of your atopic dermatitis. Nowadays, our colleagues are also using Dupilumab in Indian patients with very good result. Let's see whether JAK-STAT inhibitor can help further in the treatment of critical patients of atopic dermatitis.
The another comment from my side, and that is on the critical comment made by Dr. Shambo regarding that 16-week and 2-week issue of Dupilumab. Dr. Shambo has mentioned that a minimum of 16-week in the FDA guideline they have mentioned, and truly speaking, that is the reason why when Dupilumab was marketed in, or rather licensed by US FDA, they wanted the protocol to be designed for maintaining the response for 16 weeks of the initial treatment. But then when it is licensed, it is 300 milligram every 2 weeks is approved for the uncontrolled moderate or to severe atopic dermatitis. So that may be the reason why they have kept it in the 2 weeks, this thing. That may be the reason. The other issue that is coming to my mind is because it's a sponsored study and Pfizer has sponsored, I am eager to know, curious to know rather, that out of these two molecules, which one actually is of interest to Pfizer. I do not know whether Dupilumab is marketed by Pfizer or the newer one is going to be marketed, and whether there has been enough conflict of interest declaration, okay, in the paper that you have read. Whether you have had a look at that, Dr.
Yes,
Shambo, your comments.
Yes, as I had mentioned while at the beginning of my presentation, this trial is sponsored by Pfizer, and actually that was mentioned in the paper too. So Dupilumab is generally a product of AstraZeneca, so they are totally towards different. So sir, with your if you are permitting, because we are running short of time, so, and Dr. Shubhobruto Moitro has some another engagement. So can we move forwards towards the next session?
Yes. I'm sorry. Yeah, that's right. For the statistical discussion.
Yes, sir.
Okay. Please.
So thank you, Professor Sudeep Ghosh sir and Professor Shantanu Kumar Tripathi sir, to chair this session.
Thank you.
And now we are moving to the final session, and one of the most important points that is the statistics talks. And to chair the session, we are really privileged to have Professor R. Ravindran sir with us, who is a professor and head at the Department of Pharmacology, JIPMER, Pondicherry. Welcome, sir. And also we have Dr. Shubhobruto Moitro, who is a senior researcher at the Division of Pulmonary Medicine at Department of Medicine, University of Alberta, Edmonton, Canada. So welcome, sir. So now the e-podium is yours. Over to Professor Ravindran, sir.
Yeah, thank you, Dr. Samajdar. What's his name? Yeah, the first paper, Saibal. Are you there?
No, sir. Now the session is on the statistics talks.
Yeah.
On that will be dealt.
No. I'm not asking him to present. I want him to explain something.
Okay. Dr. Dr. Shoibal is having some meeting in the, so he had left.
Okay, fine.
Dr. Ravi, because the speaker for the statistics thing, Dr. Moitro, I think, Shubhmoy Moitro, he has some other commitment at 4 o'clock. So let us hear him.
Yeah.
Dr. Shubhmoy Moitro.
Thank you, Dr. Samajdar, for inviting me. This is really wonderful session going on, and unfortunately, I have another meeting with my collaborators in Europe, so I have just 15 minutes left. So let me share my screen. I have made my presentation very small, And I just wanted to highlight a couple of things on statistics and why we should make statistics. I think I made the share wrong screen. Can you see this slide now?
Yeah, it's visible.
Okay, okay.
Make it full screen. Yeah, nice.
Okay, so I'm not a professor. I'm a senior researcher at the University of Alberta in Edmonton, and I'll be spending the next few minutes to describe some fundamental facts on statistics, particularly medical statistics. And for today, I choose this article because this when I saw this article, it was very interesting to me, and I found some very interesting statistics in this particular paper. So, but before I say something about the statistical part of this paper, I have to say you something that because I am more interested in epidemiology, we consider terms very seriously, and confounders, mediators, these are very, very specialized terms. And I have seen that these are often used very randomly without having a proper understanding of what these are actually and what statistics define them. So I'll be very brief to give you some highlight about three particular aspects on covariates and how these are defined in different terms. So first is the confounder. So what is a confounder? As a pharmacologist, you have read hundreds of clinical trial papers, and you have come across this term confounder very often. And so the general perception is that there is one independent variable, maybe a drug, there may be an outcome variable, maybe an effect, and rest of these two are confounders, which is actually not. So a confounder is a third variable in the exposure response pathway. So you can say this independent, that is I, and the dependent is a D. So the independent variable, that may be a drug, maybe any kind of exercise testing or whatever, and the dependent variable is an outcome. So a confounder is the third variable, not shown here as of now, which is associated with both the independent and the dependent variables. So like this. And remember the arrowhead, So remember the arrowhead. So the arrowhead is from the confounder towards the independent variable and towards the dependent variable. Now, I'll give you an example how confounder could be selected from study. Let's talk about lung function and mortality. So lung function, if I take lung function as an independent variable, so lower lung function could be a cause of mortality or could be associated with mortality. So mortality here is a dependent variable. And impaired lung function or lower lung function is an independent variable. Now, if I want to create a model with age in the model, then where age should stand? Age should be is considered as a confounder in this particular model. Why? Because age has two-way role in the model. One, that we know with advancement of age, there is a lower lung function. And also with advancement of age, there is a higher risk of mortality. So age in this particular scenario has a dual effect both on the independent variable as well as on the dependent variable. In this particular case, age is a confounder. Now, I'll give you another example of a mediator. So what a mediator is, now look at this direction of this arrow. So in the confounder, the arrowhead was from confounder to independent variable. And here it is showing a path that is that there is a direct path from independent to dependent, and there is an indirect path from independent to a third variable that leads to the dependent variable. So a mediator or a mediating variable is a variable that links the independent and the dependent variables, and whose existence explains the relationship between the other two variables. Now, I give you an example how a mediator works. Now, we all know that smoking causes COPD. In a similar fashion, smoking, first, we can explain this in a pathway that smoking first reduces the lung function, and this reduction of lung function leads to the COPD. Now, while this direct path is true, the indirect path is also true. So if we remove the direct path, smoking causes COPD, the indirect path still persists. That says smoking reduces the lung function, that ultimately leads to the progression of or the development of COPD. Now, here we cannot say that lung function causes smoking. That way we saw the confounder working, that age reduces lung function. But here, lung function is an outcome of smoking, not the other way around. So we cannot say, we must have to understand the directionality of the arrowheads. Now there is another area, another thing, which is called the effect modifier or interactor variable. And that is that effect modification occurs when the magnitude of the effect of the primary exposure on an outcome differs depending on the presence of a third variable. Now, as you can see over here, there is a third variable, y, that has only one direction on the dependent variable. There is no direction on the independent variable. So y, the presence of y doesn't do anything on the independent variable. Rather, the presence of y has a very strong effect, or this very strong role on the outcome. Now, I'll show you an example. So, like as we know, asbestos is a risk factor for cancer. Now, we all know that smoking is also a risk factor for cancer, but there is apparently no relationship between being exposed to asbestos and smoking. We cannot say that if you are exposed to asbestos, you are a smoker, or the other way around, like if you are a smoker, you are exposed to asbestos. So basically, this pathway does not exist. The only path that seems to be logical is from this particular third variable to the outcome variable. So when we have to consider covariates in the model, we have to be exclusively critical how these covariates actually work. And we have to basically make a drawing on a paper with our pen. And that was the exact thing that was done in that BRJ paper, that they prepared a DAG. So I'm trying to explain you the DAG a little bit, and we'll try to tell you what are the flaws in that particular DAG. So what is a DAG? These are all DAGs. So DAG is a directed acyclic graph. So it has two phrases. One is the directed, so this has a direction, and acyclic. So it shouldn't be cyclic. It has to be an unidirectional, not a circular or a bidirectional relationship. So if the arrowhead is in this way, but if the arrowhead would have been here, it would go like this from smoking to lung function to COPD and back to smoking, which is not. So it is directed, it has a direction and acyclic. Now, I just want you to look at this table. Actually, Dr. Das had made a couple of points, and he had made my task quite a bit easy with all his explanations about the residual confounders and so on and so forth. I just want you to look at this particular table, and because we all know that table 1 is very important in a paper, and this gives us the impression of how further analysis were performed, what are the interpretations, what the distribution of the variables, and if there is anything that we should know from the study design. So we have a couple of demographic factors: age, sex, weight, height, BMI, waist height ratio. We have a sum of skin folds, and we have a list of comorbidities, and this is our dependent variable, death and follow-up time. So these are the variables that we have in this paper, and all the subsequent analysis were done on particularly only on these variables. Now, the authors, they made it very deliberate to present this DAG. Usually in clinical epidemiology papers, people don't use DAGs very often in the main paper, because this is a concept. This is a very qualitative approach how one should consider the covariates in the model, and that's it. So basically, what we do with a pen and a paper, we are now doing this on a computer screen with a software or with a web program. So basically, this is very simple. This is used only to understand the relationship between the variables. There is no need to present this DAG in a paper. However, the authors did it, and they probably did it very deliberately. Now, I tell you why the DAG, why this particular relationship had serious issues. First of all, you will see that there are two variables listed in this DAG: vital status and clinical status. Now, if you simply do a Control F on the PDF, you will hardly notice these two terms. So the clinical status was mentioned probably once without clear indication what it is, and vital status only is in the figure legend, nowhere else. So the first thing is that when you prepare a DAG, you have to understand the variables very well. You have to explain them if you really want to present a DAG. But here you are presenting two particular variables which apparently have no further information in the paper. Nobody knows where they are, what they are, how they are measured. So these are kind of eye-washing and is a serious issue. Otherwise, they could have explained it very well in the supplement, or maybe in appendices in the paper, or somewhere in the paper that we have used clinical status for these and these variables, or vital status for these and these variables, which they didn't. So this is the first one. Next is the building of the DAG. So the building of the DAG is itself erroneous. Now, I'll tell you why this model. So they prepared this DAG and this conceptual framework, this model, to explain how they analyze the HR, the hazard ratio. Now, I will not talk about, because of the time limitation, I will not talk much about the hazard ratio, but I'll try to explain why the hazard ratio results could have serious flaw. So they use what they say in the DAG, that they created this model and they have some covariates like age, sex, body mass index, and clinical status. So clinical status seems to be healthy versus unhealthy. It is not mentioned anywhere in the paper, not even in the table 1, what is meant by healthy versus unhealthy. So I am assuming that healthy versus unhealthy could be categorized based on the number of comorbidities. So people who without any comorbidity had a clinical status healthy, and people with comorbidities were unhealthy, or maybe people with only one comorbidity were healthy and multimorbidity were unhealthy, which is not explained at all. So what they say that age, sex, body mass index, and clinical status were considered as a confounder. Fine. But are they true confounders? So if we go particularly with the consensus of the preparation of JAG or the explanation of JAG in terms of clinical epidemiology, we will find that there are two particular variables which have not been shown to have direct association both with the independent and the dependent variable, as we know how confounder works. First is the BMI. So if you see the BMI has an arrow towards the independent variable. Fine, fair enough. But it does not have a direct arrow towards the dependent variable. Instead, what it has an arrow to clinical status. And then as an arrow goes from clinical status to vital status. So at this particular juncture, BMI is considered as a confounder in the model, but not clinical status. So clinical status in this particular model becomes a proxy confounder. And you cannot have a confounder and a proxy confounder in the same model. Again, you can see that sex has a direct arrow towards the dependent variable, but not on the independent variable. Rather, it goes to either clinical status or BMI, and then goes to the independent variable. Now, again, in this particular model, BMI, if we go this way, BMI is a proxy confounder. So if you take both BMI and sex in the same model, the model is erroneous. Or if you take sex and clinical status in the same model, the model itself is erroneous. So this entire DAG has serious limitation. It's not actually a true representation on how you select confounder. Now, even if I take, okay, fine, they have selected these confounders, they have explained all these variables, still there are some limitations. And I tell you why these limitations need to be rectified or need to be taken into account. First of all, in general sense, what we can say that having a higher BMI may lead to some unhealthy clinical status. So higher BMI could lead to hypertension, higher BMI could lead to obesity, or any other chronic heart failure conditions or something like that. So in this way, BMI is actually a predictor of clinical status. Now, when you have all these things in the same regression equation, there could be a possibility that one of those covariates can actually influence the other covariate. And this is called an event multicollinearity or autocorrelation. What it does when we construct a regression model, so this is an X and this is a Y, this is X1, this is Y, and these are all different X's, X2, X3, X4, X5. So when we we construct a regression model, we first test the association between the independent variable and the dependent variable using a simple regression equation, which is called the univariate model. Then we start including the covariates either based on statistical criteria or based on a priori evidence, and either in a step forward way, like one after one, and or step backward, like we recruit all the covariates in the model and start deleting them. What happens that sometimes if we use two covariates which are very much collinear or which have very high correlation, they have a nullifying effect on each other. And this is a very pertinent problem in clinical research because of lack of understanding on how models are to be selected, model fitting criteria, and it is not something that you construct a model. When you construct a model, you have to understand whether the model is stable enough, or what is the diagnosis of the model? What is the diagnostic criteria of the model? Does my model stand if I remove one variable, or if I add one variable, or if I want to extrapolate my model into a bigger sample size? So, for example, I give you an example like for example, I'm a carpenter and I was given an order to make a cabinet for a house. So I took the measurement of the cabinet as ordered. I took the measurement of the room where the cabinet would be fitted, and I made the cabinet very well decorated and so. And when I went to install the cabinet into the room, I found that I made a great mistake. And the mistake was, I did not measure the size of the door. So I made a cabinet of 8 feet long and the door was 6 feet long. So I prepared a model, fantastic, but the model was not at all replicable or at all reproducible, at all applicable to that particular context. Then the parsimony or the suitability of the model does not exist. In this case as well, they have constructed very high-fi models. They have used many sophisticated techniques. Apparently, they were not at all required, but they used, I don't know why, to be more kind of generating more impression that they were doing something extraordinary, and they made a great mistake. So when they generated this model, what they could have done, this very simple test, they could have calculated the variance inflation factor, otherwise known as VIF, and they could have shown that, okay, I have taken 1, 2, 3, 4 covariates, and the covariates do not have any collinearity. They did not need to write a half page with all those different C criteria and XYZ. Those are all needed. So what they did to establish the suitability of their model, they could have done it in a single line. Now, why I am saying so, what is my gut feeling? I'll tell you that. So if you see in this particular table that the model 2 was only adjusted by age. There was no adjusted by sex or adjusted by BMI or so. Now here there's the comorbidities, but in the DAG they say that it was some physical what was that clinical status. So this is wrong. You have to be consistent with the name of your variables, which they didn't. So what we see over here, that all-cause mortality, the hazard ratio is 2.18, and the p-value is less than 0.01. What happens when they further adjust the models with sex, BMI, and comorbidities. The hazard ratio drops down by 30 units. Now, why is it so? There could be two reasons. One, there is a natural trend that when you include more and more covariates in the model, the outcome, the hazard ratio or odds ratio or the regression coefficient beta or whatever, it generally stumbles. It falls down to a particular degree. But here, just by adding 3 more covariates, it fell down to 30 units, which is huge, which is not minimum. So I am assuming that there is a very strong possibility that the BMI and comorbidities had a very high degree of autocorrelation. And that's why they nullified each other's effect and led to this drop. So that was it. I just wanted to pull out a couple of the drawbacks of the models used. Unfortunately, I'm just going out of time. So, but thank you so much for listening, and I'll be happy to join you again sometimes later.
If you can stay back for a few minutes more, Dr. Ravi can have your comments. Yeah.
In fact, no. He explained it very nicely, and that shows his knowledge in statistics and other things. Well, I'm not well versed with this kind of advanced statistics and other things. But I was looking at the table. Can you go to the table 3?
Yeah, sure.
Yeah, the table 3. In fact, no.
Oh, table 3, yeah.
Presenter. No, that model, yeah, model. See, table 2, sorry, table 2. Yeah, this one. So this is exactly, this was, when I was looking at it, I was not very convinced, that is what I wanted to ask the presenter, but you explained it very well. Now, my doubt is, suppose you adjust with everything, age, sex, BMI, and comorbidities, that means what is causing this, the people to fail?
It's not significant. Yeah, the p-value is non-significant in this case.
Sorry, no.
P-value is 0.003 here.
Yeah, 0.003 is less than 0.05, no.
Okay.
Significant, it's still significant.
Significant, it's still significant. Okay.
No, my question is, you adjust with all the comorbidities, BMI, sex, and age. In that case, what is causing the people to fail?
Okay, I understand. So, yeah, so what?
The one leg stance is not the cause of mortality. Am I right? Now you adjust everything, then what is causing that mortality? And what is causing the people to fail?
Exactly. So apparently, if we just postmortem this covariates, apparently what we should expect is that comorbidities would have a very high possibility for this mortality associated with this stance balance test. But I think the comorbidities had almost no effect in the model.
But would you agree that when you talk of comorbidities, it is too much a heterogeneous kind of confounder, because the nature of the different comorbidities or different diseases which has different impact. In fact, whether if it is diabetes, how long the person was suffering from diabetes, whether the diabetes was controlled, whether another person would be, say, heart failure. Okay, and you are taking all these people and you are trying to see, and is it enough to just try to define all these people by one word, and that is comorbidity? How fair is that?
Well, I would agree. I mean, there are so many limitations. First of all, I don't have any understanding on how comorbidity was actually considered. So comorbidity could have been classified as a dichotomous variable, yes or no, or when they say that they considered comorbidities as coronary artery disease, systematic arterial hypertension, dyslipidemia, and diabetes mellitus. So 4 comorbidities. Now, if comorbidity is a continuous variable, I mean, an ordinal variable, account variable 1, 2, 3, 4, number of comorbidities, or it is a simple binary classification, or how they assess the comorbidity. That's my biggest question, because we usually use either Carlson comorbidity index or Elix-Hauser comorbidity scale for comorbidity assessment. And they haven't mentioned, I didn't find any particular mentioning about how comorbidity was classified. So either way, you can get a score. So from Carlson as well as in Elix-Hauser, you get a score, and based on the score, you can say whether the risk of comorbidity is high or not. But having comorbidities exactly like 1, 2, 3, 4, or just by random diseases makes no sense actually to me.
Yeah. Okay. So
thank you.
Yeah. Dr. Maulik, are you there? Dr. Subir Maulik?
Yeah, I am here. Can you hear me?
Yeah, please.
Oh, it was an excellent dissection, or what you say,
Yeah.
post-mortem by
Right.
Dr. Mel. Thank you very much indeed. And I think Dr. Ravindran has hit the final nail by saying, that was very interesting comment. So this is why this paper was very, very, very interesting to me. My major emphasis again on the mechanistic hypothesis, that why do you think that 10-second OLS will be mechanistically related to an adverse cardiovascular outcome? I still don't understand. What is the mechanism, as Shantanu has also agreed with me. So the whole paper has certain flaws, and I am very distressed to know that it has been published in BMJ, none other than BMJ.
Yeah.
Anyway, thank you very much, Silverberg, for very nice dissection. I am very impressed by your, especially this effect modifiers, mediators, and confounders, nicely described. And you should
Thank you, sir.
think in the web of IPS, so that the youngsters can read it at their own time. Thank you very much.
Thank you, sir. Thank you so much.
I have a last comment that whether Dr. Ravi, Dr. Maulik, and Saibal, if Saibal is there, Shambo, and of course Dr. Moitra, that if we think of having a similar study, okay, designing a protocol for a similar study with the apparent lapses or limitations of this study not to repeat, that how we should go. Can we think of having a follow-up meeting on this with Dr. Moitra also to help us, okay, and Dr. Maulik and Dr. Ravi, if you are interested. I think when I selected this particular article, I had all this in mind, that they are trying to actually highlight otherwise very simple test, okay, that 10-second OLS, if really it can be validated, this will be a great contribution, in fact. But maybe there are some methodological or procedural design related limitations and flaws, but definitely they are correctable. Why not think of some kind of a prospective study, okay, over say 5 years or over 10 years? We can think of this, Dr. Maulik.
Yeah, perspective, very, very
yes,
important.
Yes,
you see, and you have to have some information about the effect of various interventions in this cohort on their performance on OLS, whether OLS is increasing or not, so that you can say that it is a valid test. I am with you. Whatever way, with my limited knowledge, I can help you in this regard. And Shambo, can you find out the basic mechanistic hypothesis for using OLS cardiovascular, that Jyoti told that it can be good for the neurological things, but not for cardiovascular. Only thing is that diabetic neuropathy can cause such things, but not other comorbid factors. I'm not very convinced about the mechanistic hypothesis of this. I would like to have Dr. Ravindran's comment on it. I have already got Dr. Shantanu's comment on it. But Ravindran, what do you think the mechanistic hypothesis wise this OLS is good or not?
Sorry, Maulik, you are asking me?
Yes, Dr. Ravi. Yeah.
Can you repeat the question, please?
No, Shantanu, can you tell him because my voice may be not clear?
No, Dr. Maulik is asking whether there is any mechanistically or physiological basis of this kind of a hypothesis that a 10-second OLS could be a good predictor or a good prognostic marker for cardiovascular mortality. What is the scientific rationale?
I'm sorry, no, I'm not in a position to answer that question.
we need to have a little
there
more
is one explanation, sir.
I don't have an answer for that.
Yeah.
Dr. Shambo, yes.
Yeah, so actually we had done this type of test specifically when I was attached with one football team. When the players are injured and out of the game for maybe more than 1 month, and then we start the recovery procedures. So initially we do this 10-second one leg test, and we need to check their power. So actually this is also related with the sarcopenia, the muscle wasting that happens during this resting period, that has a direct impact on this OLS2. Not only the neurological thing, yes, neurology and nervous system, the autonomic nervous system, they have impact on this, but also this muscle reflex, which is very much related to the sarcopenia. And we all know that with elderly, with aging, we lose our muscle mass. So that is also very much related.
How do you relate it with the cardiovascular mortality?
So
why should muscle weakness be related to cardiovascular mortality in future? Okay.
So sir, actually when we are talking about muscle weakness, then whole the game is like sarcopenia, and this muscle weakness is related with insulin resistance again. So we all know that when we are talking about insulin resistance, again there is something which is happening in our vascular system, and which may have some negative impact on our cardiovascular life.
Yeah.
So sir, actually it is a very good proposal whether we can have a good design, because very soon under the guidance of Professor Jyotirmoy Pal sir, because Jyotirmoy Pal sir had left, we are going to start one large epidemiological study in West Bengal, in different rural area though. Also we are trying to capture our urban population in some setting. So we can have this, because this is a very simple test, and we can check this, and we can also follow up them maybe for 5 years like that, and we can take the outcome. So we need your guidance.
That is great. Shambu, I think you can collaborate, talk to Dr. Saibal, because he's in Center for Aging and Mental Health under ICMR, and you can look for some opportunities of funding to him, because he has a very good standing in headquarters. You know, I'm telling you, when he left headquarters, many people were very unhappy. Not only BMS, but non-communicable disease division, they all wanted to retain him. So you use him also to have some funding.
Okay, sir.
And we have our BMS head, Dr. Narendra Chatterjee from NICET. This group with Ravindran giving the support about designing, and all these things can be done. And as you have said, it will be a good study. In short, I must say.
Can I just say something?
Yeah, please.
So one thing I would definitely do is to do a sensitivity and specificity analysis of this particular test, because without this, whether the test is at all valid is not established.
Right.
So I would definitely go for an ROC analysis to see how sensitive and how specific this test is for any kind of, while assessing any kind of outcome.
Okay. Great.
Okay, I bet you go. Thank you so much. Thank you so much.
Thank you.
Thank you. Thank you. So we are really overwhelmed with the response from our respected chairpersons and speakers today. And though it is overshoot almost 1 hour, so we have a plan to end it by 3:30. Now it is almost 4:30. So we are really thankful to all the chairpersons for being with us and the speakers for giving their valuable time on behalf of Indian Pharmacological Society West Bengal chapter and Inovocare e-Academy. We are really thankful to all of you. And also we are really thankful to all those delegates. So today we have almost 100 delegates today with us. So we are really thankful to all those delegates. Though now it is 37 participants are there till. So I have one now duty to announce the prizes. So prizes means we are going to deliver some certificate of appreciation to our participants in this journal club competition. And for that we have almost 28 participants. And we are really thankful to Professor S.M. Nasir, Professor Shukanto Sen, Dr. Chiranjeev Bagchi, and Dr. Arunabho Vishwas for their time and for their valuable correction and their scoring to those appraisal. And according to their appraisal, I am just now going to announce the first, second, and third prize, and that will be a certificate of appreciation to be given on behalf of Indian Pharmacological Society West Bengal chapter and also Inovocare e-Academy. So the third prize goes to Dr. Archana Bandkar. I don't know whether she is there. If you are there, so you can raise your hand so that we can unmute you. The second prize goes to Dr. Aparna R. So if you are there, you can unmute yourself. You can raise your hand so that we can unmute you. And the first prize goes to Dr. S.P. Dhania. So congratulations all of you. First prize, Dr. S.P. Dhania. Second prize, Dr. Aparna R. And third prize goes to Dr. Archana Bandkar. So congratulations all of you. If some of you are there in this delegate list, you can raise your hand so that we can unmute yourself and we can ask your experience today. Okay, so I think they are not there, so no problem. We will send their certificate of appreciation soon. So with that, I thank you all again for being with us for almost 2.5 hours. So we have a plan to organize this type of session in near future. And first of all, we must we are really thankful to Professor Shantanu Kumar Tripathi sir, because this journal club is his brainchild. And please sir, guide us in our near future also, so that we can organize more such brainstorming events. So we are thankful to Professor Ravindran sir, Professor Subir Kumar Maulik sir for giving their time with us. And we are also very much thankful to Professor Jyotirmoy Pal, Professor Sudeep Ghosh, and Professor Shubhobroto Moitro. And we are really overwhelmed to have the first journal club session by Dr. Saibal Das. I think that could be a model journal club presentation, and that these total presentations or recording will be kept in our website, Indian Pharmacological Society West Bengal chapter website. So you can go through that, and we are really thankful to Dr. Saibal Das. So with that, I thank you all, and Jai Hind, Namaskar.
Thank you.
Thank you. Bye.
Bye-bye.